Hello everybody and welcome once again. Today we are going to look at the concept of the nutrition care process, and this is our second class in the principles of diet therapy or diet therapy 1. And I would like us today to understand the nutrition care process, the steps of the nutrition care process, how to write phase statements and enteral and parenteral nutrition. The nutrition care process is simply a systematic approach to providing high-quality nutrition care. In 2002, the Academy of Nutrition and Dietetics, and that was formerly the American Dietetic Association, created the nutrition care process, NCP, as a way to improve consistency and the quality of individualized care for patients and the predictability of patient outcomes. So the goal of NCP is to basically standardize the process for providing nutrition care. And we have basically 4 steps that are involved in the NCP that form a framework for the registered dietitians to create an individualized nutrition plan. So the first step in the nutrition care process is nutrition assessment and reassessment. And this begins when a referral is made to the dietitian or the nutrition professional. The key components the dietitian will look at are grouped into 5 categories. One is the food or nutrition-related history, the anthropometric measures, laboratory tests, medical tests and procedures, nutrition-focused physical findings, and client history. And in nutrition assessment, you can also use the approach of ABCD, where A stands for anthropometry. You measure the body measurements such as height, weight, and then also B stands for biochemical assessments, where you take the measurements of the body fluids to determine any deficiencies. And then you C is clinical assessment. You look at the patient clinically and you observe from head to toe and you find out exactly what they are suffering from. And then D stands for dietary assessment, where you assess the diet history. How has this patient been feeding? And many dietitians usually begin by talking with the resident or the family, assess weight history, usual diet patterns, any food allergies or intolerances, any difficulties chewing or swallowing, and any nutritional concerns. A patient's clinical record and nursing, the dietary and the therapy staff will also serve as good resources when assessing the nutritional status of a particular patient. The second step is the nutrition diagnosis. Once you have finished assessing the patient, the next is to diagnose what is this patient suffering from. And this one leads to nutrition assessment and intervention. The registered dietitian will identify and label a specific nutrition diagnosis that the dietitian is responsible for treating. And here we have to make sure that standardized language is used, and it has also been developed that is used in identifying a nutrition diagnosis. It is always very important to note that the nutrition diagnosis is not a medical diagnosis. These are 2 separate concepts. This patient will be diagnosed medically and also nutritionally. And the nutrition diagnosis you should make sure that it is clear, concise, and related to only one problem. It has to be based on reliable, accurate assessment data. And the third step is the nutrition intervention. And this one includes planning and implementing a plan that is focused on the nutrition problem that you have identified in the diagnosis. It also includes discussing with the patient and other members of the interdisciplinary team to discuss the realistic goals and create a plan to reach that goal. And often in the long-term care settings, these interventions may include altered diet textures or consistencies, diet liberalization, and providing nutrient-dense supplements. This is where now you prescribe the patient with various types of diets according to what they're suffering from, and other recommendations such as physical activity. And finally, the last step is the nutrition monitoring and evaluation. And this one you have to monitor the progress that has been made by the patient. And it links back to the first step, because once the dietitian has finished assessing, the progress made in weight status, the meal intake, the labs and nutrition forecast physical findings. Then now we can track how this patient has been progressing. In the long-term care sector, the dietitian will monitor the patient's progress on an annual basis if the patient is nutritionally stable. But a patient who is not stable, you can end up even monitoring weekly or even monthly, depending on how critical the situation may appear. And more frequent nutrition monitoring is done if the patient is at a higher nutritional risk, for example, decreased meal intakes, weight changes, skin ulcerations, or receiving nutrition through tube feeding or parenteral nutrition. In the nutrition diagnosis, the most unique feature of the nutrition care process is the nutrition diagnosis, and it is basically divided into three. We diagnose according to intake, the clinical and behavioral or environmental factors. We have 60 nutrition diagnosis terms and definitions that were developed to describe nutrition problems that can be treated independently by the dietitian, and they are distinct from the terms that physicians use to describe medical diagnosis. So nutrition diagnoses are very specific to nutrition, and medical diagnosis, and they also focus on only the medical aspect of this patient. However, I find that the dietitians and physicians may use a similar process of diagnostic reasoning to derive diagnosis from their respective domains. Uh, as in the medical diagnosis, the nutrition diagnostic terms have a specific definition, unique etiologies, those are the problems, and then signs and symptoms, and a code number that may be used for linking to the data in the electronic medical records. So once the registered dietitian makes a nutrition diagnosis, the term that is incorporated into the nutrition diagnosis statement or PACE statement is composed of three parts. The first part is the problem. What is wrong with this patient? Once you have found out the problem, then the etiology. What is causing this problem? And then the signs and symptoms. What are the manifestations of this problem in the patient? And also that stands for the PACE statement. So within your PACE statement, the diagnosis is a nutrition problem that will resolve with the dietitian's intervention. You have to make sure you diagnose a problem that is going to be able to be treated nutritionally. And then the etiology, you have to find out the root cause of the nutrition problem. Can it be improved or be eliminated with the nutrition intervention? And then the signs and symptoms. Can they be monitored by the dietitian to determine progress towards resolving the nutrition diagnosis? So you have to be able to ask yourself these questions. So in table 1, we are going to basically go through the PACE statement, the three parts of the nutrition diagnostic statement, or the PACE statement. So the general format is PES, problem, etiology, then signs and symptoms. And your statement has to be in such a way that you state the problem, and then you say that this problem is related to such and such a cause, that is the etiology, as evidenced by such and such signs and symptoms. So for example, P, some of the nutrition problems you can have: inadequate intake of potassium. What is this inadequate intake of potassium caused by? It is related to increased urinary losses with amphotericin. This is related to drug intake that has increased urinary excretion of potassium. And B, administration. So we're having inadequate intake of potassium related to increased urinary losses with amphotericin B administration, and this is evidenced by the declining serum potassium levels, and this is the sign that is showing us that there is inadequate intake of potassium. The evidence here is the declining serum potassium levels. So your clear PACE statement here will be inadequate intake of potassium related to increased urinary losses, amphotericin B administration as evidenced by declining serum potassium levels. And then now you go ahead and prescribe the patient once you have stated the problem or the problem statement and the diagnosis. You go ahead and now prescribe. What is your intervention? Sample prescription. Increase the potassium intake to 2 micro equivalents per kilogram each day. Then the nutrition intervention. The mineral potassium levels has to be 40 per day of the supplements as needed to maintain the serum potassium levels within normal levels. And that is your intervention. And finally, you have to also have a systematic method of the nutrition monitoring and evaluation. Monitor the potassium intake and the serum potassium levels. You have to note that the PES and the numbers for the nutrition diagnostic term, the N155.1, the nutrition intervention term, and the nutrition monitoring and evaluation terms are included for the convenience of the reader. So your nutrition intervention is defined as a specific action that remedies a nutrition diagnosis and consists of two components, the plan and the implementation. The intervention is divided into four main domains. One is the food or nutrition delivery. The kind of foods you're going to prescribe for this patient. What are they suffering from? And what kind of foods are they going to consume? Two, nutrition education. After prescribing this diet, does the patient know how to use this diet? Then you give the patient nutrition education on how to give this to use the specific food or diet prescribed. And then nutrition counseling. The patient has to be prepared mentally, physically, and emotionally to start the nutrition intervention strategy. And finally, the coordination of care. You have to also talk to the family members of this patient so that this intervention may be implemented so that they can also help the patient to overcome the problem. And our first step in planning the nutrition intervention is the nutrition prescription. The prescription has to be based on the best available evidence and the clinical judgment of the dietitian. It is not the current nutrition order, but rather an individualized statement of the needs of the patient at a given moment in time. So you have to give the prescription according to the needs of that patient at that given time. But in critically ill patients, the prescription may be adjusted frequently as medical diagnosis. For example, acute renal failure, hepatic encephalopathy treatment, such as the surgical procedures and also the patient's condition. So the purpose of our intervention is to correct the nutrition diagnosis, to remove the cause and reduce the signs and the symptoms. That has to be your main focus. And finally, the nutrition monitoring and evaluation. This is our final step. And this is defined as the review and measurement of the patient's status at a scheduled or pre-planned follow-up point with regard to the nutrition diagnosis, intervention goals, and outcomes. It is also organized into four domains: the food or nutrition-related history outcomes, anthropometric measurement outcomes, biochemical data, medical tests, and the procedure outcomes. The nutrition-focused physical findings outcomes as well as the comparative standards. So you have to put all these into your consideration. The food or nutrition history outcomes and anthropometric measurements are the most frequently used. Evaluation is the systematic comparison of the current findings with the previous status, interventions, goals, or a reference standard. So you have to evaluate. After monitoring, you evaluate now. What results have you obtained from the interventions that have been provided to the patient? And what is the improvement? So the effectiveness of the intervention is also monitored by changes in the signs and symptoms as listed in your case statement. You have to make sure that you monitor the signs and symptoms. The disappearance of those signs and symptoms is going to evidence to you that your intervention is working or the patient is applying the intervention. So for example, in our table 1, the intervention, potassium supplementation, should resolve the nutrition diagnosis and can be monitored using the sign, that is serum potassium levels, in the case statement. So you have to monitor the serum potassium levels periodically. Also, your monitoring and evaluation step incorporates changes from the baseline in biochemical and medical tests, anthropometric data, the intake and output, and other familiar nutrition support monitoring parameters. And it also incorporates the familiar components of the nutrition support, dietitian's assessment, in a more systematic approach, which enables the measurement of nutrition outcomes and the ultimate descriptive demonstration of the dietitian's effectiveness. And after the monitoring and evaluation, so our four first steps of the nutrition care process, we have the nutrition assessment, and then diagnosis, intervention, and finally monitoring and evaluation. So nutrition support involves both parenteral and the enteral nutrition. And malnutrition is both a cause and a consequence of ill health. It is common and it also increases a patient's vulnerability to disease. There are various methods to improve the nutrition status, and this is known as the nutrition support. Nutrition support can be in form of oral nutrition support, for example, giving the patient fortified food, additional snacks, or seed feeds. And then enteral tube feeding. This involves the delivery of a nutritionally complete feed directly into the gut via a tube. And then parenteral nutrition, the delivery of nutrition intravenously. So these methods can improve the outcomes, but decisions on the most effective and safe methods are also a bit complex and they require the interdisciplinary approach. The indications for nutrition support in the hospital and the community. Nutrition support should be considered in people who are malnourished, and this malnutrition can be defined by any of the following. 1. The patient has to have a BMI of less than 18.5 kilograms per meter squared. This is a sign of undernourishment or severe malnutrition. And then the case of unintended weight loss that is greater than 10% within the last 3 to 6 months. A BMI of less than 20 kilograms per meter squared. And finally, unintentional weight loss that is greater than 5% within the last 3 to 6 months. The support should also be considered in people who are at risk of malnutrition. And this risk of malnutrition can be defined by having to eat little or nothing for more than 5 days, or maybe the patient is likely to eat little or nothing for the next 5 days. The patient may also have a very poor absorptive capacity and a high nutrient loss level. Or the patient may have increased nutritional needs from causes such as catabolism. The healthcare professionals involved in starting or stopping nutrition support should make sure they obtain consent from the patient if she is competent. Or maybe they have to also act in the patient's best interest if he or she is not competent to give the consent. You also have to be aware that the provision of nutrition support is not always appropriate. The decisions on withholding or withdrawing of nutrition support require a consideration of both ethical and legal principles. And this can be found at the common law and the statutes, including the Human Rights Act of 1998. So what should you give to patients in the hospital and the community? We have to make sure that the patient is giving energy, protein, fluids, electrolytes, mineral, micronutrients, and fiber needs. And then the activity levels and the underlying clinical condition. for example, catabolism and pyrexia fever. You have to take this into consideration. And then the gastrointestinal tolerance, the potential metabolic instability and the risk of feeding problems. And finally, the likely duration of the nutrition support. People who are not severely ill or not at risk of refeeding syndrome, there are some suggested nutrition prescriptions for the total intake, and they have to provide at least 25 to 35 kilocalories per kilogram per day, 0.8 to 1.5 gram protein per day, 30 to 35 milliliters of weight per kilogram, and then adequate electrolytes, minerals, and micronutrients. So, how do we monitor nutrition support in the hospital and the community? Here we find that the health professional should review the indications, the routes, the risks, benefits, and the goals of the nutrition support at regular intervals. The time between review also depends on the patient care, the setting, and the duration of the nutrition support. So people having nutrition support in the hospital should be monitored by the healthcare professionals. And the professional should also refer to the protocols for nutritional, anthropometric, and clinical monitoring when they are monitoring people having nutrition support in the hospitals. Enteral tube feeding in the hospital. Enteral tube feeding refers to the delivery of nutritionally complete feed via a tube into the stomach, the duodenum, or the jejunum. And the indications here should consider the enteral tube feeding in people who are malnourished or at risk of malnutrition. And maybe this patient also has inadequate or unsafe oral intake, then a functional, accessible GIT. The enteral feeding should be stopped when the patient is established with adequate oral intake. There are also surgical patients who are malnourished and meet the criteria for use of enteral feeding and also are due to undergo major abdominal procedures. They should be considered for preoperative enteral tube feeding. The general surgical patient should not have enteral tube feeding within 48 hours post surgery unless they meet the criteria for use of the enteral feeding. The route of access. People in general medical, surgical, and intensive care wards who meet the criteria for the use of this enteral tube feeding should be fed via a tube into the stomach unless there is upper gastrointestinal dysfunction. And those who meet the criteria for use of the feeding with the upper GI dysfunction or inaccessible upper GIT should be considered for post-pyloric or duodenal and jejunal feeding. We have what we call gastrostomy feeding. This should be considered in people that are likely to need long-term, that is about 4 weeks or more, enteral feeding. People with dysphagia, this is impaired swallowing. The patient cannot swallow safely or take sufficient energy and nutrients orally. They should have at least 2 to 4 week trial of nasogastric enteral tube feeding. And this should be conducted by trained health professionals. The mode of delivery for people being fed into the stomach, bolus or continuous methods should be considered. And we have to also take into account the patient preference, the convenience, and the drug administration. The NG tube should be delivered continuously over 16 to 24 hours daily. How do we manage these tubes? You have to make sure that this tube is studied by healthcare professionals with the relevant skills and training. And the position of all the NG tubes should be confirmed after placement and before each use by aspiration and pH graded paper. The initial placement of the post-pyloric tube should be confirmed with an abdominal X-ray. So there are some complications that are common to the enteral tube feeding, such as irritation or infection, displacement of the tube, aspiration, clogging of the tube, metabolic complications, gastrointestinal complications, nausea, diarrhea, and many others. So, parenteral nutrition in hospital and community. What are the indications for parenteral nutrition? The professional should consider parenteral nutrition in the people who are also malnourished or at risk of malnutrition, and they have to meet each of one of these criteria. One is inadequate or unsafe oral and enteronutritional intake, and then a non-functional or inaccessible or perforated gastrointestinal tract. The prescription should be introduced progressively and closely monitored, usually starting at no more than 50% of the estimated needs for the first 24 to 48 hours. This care can be withdrawn once the adequate oral intake can be tolerated. And withdrawal should also be planned and should be stepwise with a daily review of the patient's progress. The parenteral feeding formula. The carbohydrates are given in form of dextrose. The proteins are administered in form of amino acids. And then the fats, we have to give it in form of the lipid emulsions. Vitamins are given as multivitamin infusions, and minerals are given as electrolytes and trace elements. Surgical patients the health professional should consider supplementary perioperative parenteral nutrition in the malnourished surgical patients that meet the criteria for use of parenteral feeding. And the perioperative supplementary nutrition should not be given to surgical patients unless they meet the criteria for use of parenteral feeding. Also, the route of access. It can also be given via a dedicated peripherally inserted central catheter as an alternative to a dedicated centrally placed central venous catheter. The administration of the parenteral nutrition via a peripheral venous catheter should also be considered for patients who are likely to need short-term parenteral nutrition, that is less than about 14 days, that have no need for central access of other reasons. The mode of delivery. You can consider continuous administration as the preferred method of infusion in severely ill people. And then cyclical delivery of parenteral nutrition can also be considered when using peripheral venous cannula with planned routine catheter changes. Management of these catheters. You have to make sure that competent health professionals should be able to carry out the management. And the catheter placement should be done by qualified professionals, and they should be aware of the importance of monitoring and managing this safely. And then there are some complications from parenteral feeding, such as line sepsis, infections, metabolic derangement or refeeding syndrome, and then fluid or electrolyte and acid-base imbalance. And then also overfeeding syndrome can occur, and it can also cause liver complications. So basically that's what we have about the nutrition care process and enteral and parenteral nutrition. Thank you.